Thank you, John, and welcome everybody. Thank you for coming this evening. I'm James Haslam, and as John said, I grew up in Winchester. I trained in medicine in King's College London, and trained in my profession of Anaesthesia Intensive Care Medicine in South London. And also during my time at medical school, I did some philosophy, and so I've always had an interest in ethics, and it's something I've kept up with various different roles, and it's kind of how I got involved with this debate. So in terms of, this is where we're headed during this talk this evening. Declaration. So I need to be straight up with you. I'm a member of an organisation called Our Duty of Care, which is the kind of healthcare wing of Care Not Killing. So we oppose physician-assisted suicide and euthanasia. But what I would like to say is that I hope to be able to argue both sides of the argument fairly, in an even-handed way, and I hope not to make a straw man in terms of the other side of the argument, and you'll be able to tell me whether I do a good job of that at the end. But I have a really strong conviction that this is the wrong way to go, and hopefully I'll explain that over the course of the evening. The other thing to say is that this is a very controversial and sensitive topic. We're going to be talking about dying. We're going to be talking about suicide. And that may be really quite close to some of you here. And I just wanted to give you a heads up that this could be quite tricky for some people. So clearly you've come to an event kind of knowing about that, but I just thought I'd mention that at the start. So we're going to look at terminology and a very brief history of euthanasia. Then the current picture internationally, the current law here in England and Wales. We're going to look at the arguments for physician-assisted suicide and the proposed model on Oregon. We're also going to have a look at Canada. We're going to look at UK polling, and then I'm going to critique the arguments for physician-assisted suicide, and then we're going to talk about a better way. I'm going to give you some examples of further reading if you want to read some more on this topic, and then next steps for you to take. And then we're going to open it up for questions. Okay? So, terminology. I think in terms of the terminology used in this debate, I think the most helpful way to think about this is about actions that are deliberately intended to cause death versus actions that aren't. So, in terms of the actions that are deliberately intended to cause death, we have assisted suicide, which is assisting another person to intentionally end their life. And this is usually self-administered by a lethal ingestion of a poisonous cocktail of drugs. Then we have euthanasia, which is intentionally ending another person's life. This is the clinician-administered IV lethal injection, or in rare cases, using a tube for a lethal ingestion. And then we have assisted dying, sometimes called medical assistance in dying, or physician-assisted death. And this is where someone who is possibly terminally ill, although not necessarily, seeks medical assistance to end their life. It can be assisted suicide. It can also include euthanasia. And patients may not be dying. Where this happens in other jurisdictions, this has often been widened to include patients who are not terminal. And so I think it's not a particularly helpful term because I think the public can mistake what that means. Assisting someone who's dying sounds like palliative care, but that isn't what we're talking about here. What we're talking about here is assisted suicide plus minus euthanasia. On the other side, some other terminology that may be useful for you to know a bit more about are the actions that do not intend to cause death. So this is kind of my day job, working on intensive care, where we have things like withholding or withdrawing life-sustaining treatments. So this is not starting or maybe removing overly burdensome or futile life-supportive interventions with the expectation a natural death will follow. Then we have palliative care. So this is the clinical leadership, care and support to prevent and relieve suffering for people with life-limiting and life-threatening illnesses. It's multidisciplinary, individualized holistic care that assesses and manages physical, psychological and spiritual symptoms and mitigates distress. And then we have something called terminal sedation, which is using sedatives to reduce a terminally ill patient's consciousness until they die. This is rarely used, and it's a last resort to relieve severe pain, suffering, and distress that other palliative care measures have been unable to treat, and always when the prognosis is within hours or days. So I told you we'd have a brief history of euthanasia. So I'm going to go back a long way. Physicians have been asked by their patients to hasten death for over 2,500 years, and yet we've resisted thus far. We should think twice before we jettison the wisdom of the ages. I'm going to quote here from the Hippocratic Oath, which is from the 4th century BC. Neither will I administer a poison to anybody when asked to do so, nor will I suggest such a course. I will abstain from all intentional wrongdoing and harm. Do you remember that phrase, first do no harm? And here in the UK, calls for euthanasia are not new. The English schoolteacher Samuel Williams published an essay entitled Euthanasia in 1870, so over 150 years ago. And this is a quote. In all cases of hopeless and painful illness, it should be the recognized duty of the medical attendant, whenever so desired by the patient, to administer chloroform or such other anesthetic as may by and by supersede chloroform, so as to destroy consciousness at once and put the sufferer to a quick and painless death. All needful preparations being adopted to prevent any possible abuse of such duty, and means taken to establish beyond the possibility of doubt or question that the remedy was applied at the express wish of the patient. And several historians have pointed to the connection between the rise of interest in euthanasia and developments in eugenics, subsequent to Darwin's theories around evolution in the mid-19th century. And this culminated in Europe with the Nazi euthanasia program, which began just before the Second World War and was named T4 after the address of a Berlin villa, which was its headquarters. It was named the Charitable Foundation for Curative and Institutional Care. Euphemisms have abounded in this debate since the beginning. The fathers of this program were a professor of law, Karl Binding, and a professor of medicine, Alfred Hosch. They published a book entitled Permission for the Destruction of Worthless Life, Its Extent and Form, in 1922. They asserted that the right to life must be earned and justified, not assumed, and those ballast lives and empty human husks had no value and warranted mercy killing. Official T4 statistics recorded over 70,000 people were euthanized, but the Nuremberg war trials found evidence for the reality of over 250,000 people being euthanized by lethal injection or gas poisoning. The T4 program started with newborns and very young children. Midwives and doctors were required to report to T4 children who showed signs of mental retardation or physical disabilities. It expanded to include older children and adolescents and other conditions, including delinquency and Jewishness. The American psychiatrist Dr. Leo Alexander attended the Nuremberg war trials and wrote this paper in the New England Journal of Medicine, tracing the roots of the Nazi euthanasia movement that contributed to the Holocaust. And this is a quote from his paper. It started with the acceptance by doctors of the idea basic in the euthanasia movement that there is such a thing as a life not worthy to be lived. This attitude in the beginning referred to the severely and chronically sick. Gradually, the sphere of those to be included was enlarged to encompass the socially unproductive, the ideologically unwanted, the racially unwanted. But it's important to realize the infinitely small lever from which this entire trend of mind received its impetus was the attitude towards the incurably sick. Bringing us up to date, it's apparent that the drive for assisted suicide and euthanasia is predominantly a phenomenon in Western liberal democracies, in Europe, North America, and Australasia. And these are places that champion the autonomy of the individual above all else. So the current law in England and Wales, suicide was decriminalised with the Suicide Act in 1961. but it remains an offence for a person to act in a way which is capable of or intended to encourage or assist the suicide or attempted suicide of another person, and it's punishable by up to 14 years in prison. There is no certainty that those assisting someone to travel to Dignitas in Switzerland, which is less than 1 a week from the UK, will not face criminal investigation or charges. And this is one of the motivations for a change in the law. So when I was thinking more about the arguments for and against assisted suicide and euthanasia, I started to look at what makes for persuasive arguments. And there's a long philosophical and rhetorical tradition around persuasion. And persuasive arguments tend to include 3 main things: pathos, which appeals to the emotions and sympathy; logos, which appeals to the reason and logic; and ethos, which appeals to authority and evidence. So Dignity in Dying is the main lobby group who have argued for many years for physician-assisted suicide. They used to be called the Voluntary Euthanasia Society. And if you have a look at their website, their main arguments fit very nicely into these categories. Pathos appeals to compassion, and their argument is that dying people are suffering and taking their own lives here and abroad. The law offers them no protection. Logos, which appeals to choice and control. People ought to be able to make autonomous end-of-life decisions to control the timing and manner of their death, so it is safe and peaceful. Ethos appeals to credibility. The UK should follow Oregon's model, which has worked safely since 1997, and a majority of the public want. So at face value, the arguments for assisted suicide are compelling. They appeal to various parts of what makes us persuaded. And I can see why people can be persuaded. Dignity in Dying's proposed model is based on what's happened in Oregon since 1997. So the Oregon model is limited to terminally ill and mentally competent adults. It requires the dying person to end their own life, assisted suicide, and does not permit another person to do it for them, euthanasia. A waiting period to give time to reflect on the decision. It requires assessment by professionals to determine eligibility and absence of coercion, and allows a dying person to die at home. The law should respect the consciences of doctors who object to physician-assisted suicide, but interestingly, another lobby group, My Death, My Decision, go further than assisted suicide only for terminal illness, and they advocate it for intolerable suffering and physical incurable conditions. So the Oregon model has been the basis for attempts to legalise assisted suicide in UK parliaments for over many of the recent years. In Scotland's Holyrood, Lib Dem MSP Liam MacArthur has tabled an assisted dying bill with similar eligibility. In Westminster, Lord Faulkner has introduced another attempt with an assisted dying for terminally ill adults bill in the House of Lords, again with similar eligibility. And though criminal law is not devolved in Wales, there was a debate on assisted dying in the Welsh Senate on the 23rd of October, which interestingly showed a majority opposed to assisted dying. So this brings us to Kim Leadbeater's bill, which came first in the private member's bill ballot. And her bill was published on Monday the 11th of November, and the parliamentary debate and vote on the second reading of this will occur tomorrow. So this is called the Terminally Ill Adults End of Life Bill 2024. So we've just got 2 slides with an overview of what the bill entails. So this is a bill to allow adults aged 18 and over who have mental capacity, who are terminally ill, and the definition will follow, and are in the final 6 months of their life, to request assistance from a doctor to end their life. And this defines terminal illness as an inevitably progressive illness, disease, or medical condition which cannot be reversed by treatment. Death in consequence of that illness, disease, or medical condition can reasonably be expected within 6 months, and it is to exclude mental disorder or disability. The applicant must be resident in either England or Wales, and 2 doctors must assess each request at least 7 days apart to ensure that the person meets the eligibility criteria. The person has a clear, settled, and informed wish to end their own life, and they have reached this decision voluntarily, without coercion or pressure. So some of my thoughts on this. This is a very broad definition of terminal illness, and I think it will be even more liberally interpreted, as we have seen in Oregon. We'll come to talk about that. There are no stipulations around the qualifications of the doctors, who are notoriously poor at predicting longer-term prognosis. They're not required to have exhausted all other treatment options. They're not trained to detect coercion, and they can struggle to reliably determine mental capacity, especially for a decision as grave as this one. It's easy to see how the 6-month eligibility and exclusions of mental illness and disability could be dropped at some later stage, as they have in other jurisdictions. Since there is no mention of intolerable suffering for eligibility, which is understandable in that suffering is a very subjective thing, it's concerning that if these other eligibility criteria are dropped in future, we will essentially have death on demand. There is no requirement for doctors to know the patient well. In fact, one must be entirely independent and not know the patient at all. And there is no provision for involvement of families in the decision. So someone could see a doctor, ask to have their death hastened, and their family may not even know or have anything to say against it and advocate. The coordinating doctor can seek a second independent doctor if the first does not concur. And it's interesting that in Oregon, only 2% of doctors prescribe for assisted suicide. So patients end up doctor shopping those few who are willing to participate. If both doctors state independently of one another that the eligibility criteria have been met, the person may apply to the High Court for approval. If the High Court decides that the applicant meets the requirements, there will be a 14-day reflection period, shortened to 48 hours if death is imminent. The applicant may then make a second declaration to request assistance to end the life. If the doctor continues to be satisfied, a life-ending approved substance to be self-administered, ingested, or by medical device would be prescribed. A person who provides assistance in accordance with the bill would not face any criminal or civil liability. The Suicide Act 1961 would be amended accordingly. So there's no requirement for the judge to meet the applicant. The courts are already overwhelmed, and this bill will add conservatively 5,000 cases per year as per Oregon or Victoria, or as many as 20 to 30,000 cases per year as per Canada or Belgium if you extrapolate the numbers. It is hard to see this as being anything other than a tick box and rubber stamping exercise, and not a genuine safeguard to prevent coercion. The use of self-administration by a medical device sounds very close to euthanasia, especially when the bill permits doctors to assist with this self-administration by medical device. So it's a hair's breadth away from euthanasia. It's difficult to see how this will not be fully extended to euthanasia when it becomes clear that there are patients who are unable to self-administer, and I'm sure that will be challenged in the courts. The bill envisages delivery of a fully state-funded assisted suicide service as part of the NHS, which goes against the proposal of the BMA that, if enacted, it should be an entirely separate service, analogous to the majority of abortion delivery. There are no UK drugs in clinical practice that are licensed for the purpose of causing death by suicide. So those of you with a healthcare background may be familiar with many of these drugs, but used to dosing regimens operating within a different therapeutic window. Assisted suicide substances have not been tested for their effectiveness in causing death or for rates of unwanted side effects. Therefore, the drug combinations used for assisted suicide are to some degree experimental, and any substance licensed for this purpose will be based on experience from other countries. The state of Oregon has used a number of different drug combinations since assisted suicide was introduced in 1997. In recent years, combinations of 4 or 5 drugs have been used, often mixed to form a bitter-tasting lethal elixir. There are significant gaps in side effect reporting, but there are reports of seizures, vomiting, regurgitation, and regained consciousness. And it's not clear what doctors are supposed to do when this happens. Hence why Canada went straight for euthanasia. See, when death becomes a therapy, clinicians end up administering general anesthetics at 10 times the usual dose, which is what you see on the right-hand side. Why do Oregonians seek assisted death? Nearly half of them cite feeling a burden as the reason for seeking assisted suicide. Thought it'd be good to have a look at what's happened in Canada. And this is where we come to the slippery slope or incremental extension. In 2014, the Canadian Medical Association took a neutral stance on assisted dying, as our British Medical Association did in 2021. In 2015, the Supreme Court ruled that federal law prohibiting assisted dying was unconstitutional. And so in 2016, the medical assistance in dying concept, which is euthanasia, was legalized for those with grievous and irremediable medical conditions and reasonably foreseeable death. Only 3 years later, the criterion for a reasonably foreseeable death, a terminal illness, was dropped. And then in 2021, MAID was made available for persons with disabilities. In 2023, Bill C7 came under review to consider MAID for competent 12-year-olds. And in 2023, the Quebec Bill 11 obliged all palliative care homes to provide MAID, and no matter if they had a faith or conscientious objection, and allows MAID by advance request for situations of dementia. And in 2024, MAID was extended to those with mental illness alone, but it's been postponed to 2027 largely because of international outcry. When equality is such a fundamental principle of British law, it is hard to see how incremental extension wouldn't happen here. We could start with a narrow legislation like Oregon, but we could end up with Canada. And even in Oregon, there has been incremental extension. There's been shortening of the minimum waiting time periods. There's been death tourism as non-residents have been made eligible to come into Oregon for an assisted death. And there's been a more liberal interpretation of what terminal illness is, including diabetes, hernias, benign tumors, anorexia nervosa. So initial safeguards, guardrails, and boundaries around eligibility criteria can so easily become barriers to access, and a right to die can easily become a duty to die, with the vulnerable pressurized to end their lives prematurely. Other groups of patients become susceptible to the same arguments of pathos, logos, and ethos used to justify assisted suicide for the terminally ill, with inevitable expansion. Another case in point is New Zealand. So an End-of-Life Choice Act was proposed in 2019. They had a nationwide referendum in 2020, and so assisted dying was made available in 2021 with a similar eligibility. Aged 18, citizen suffering from a terminal illness, likely to end their life in 6 months, with an advanced state of irreversible decline in physical capability, experiencing unbearable suffering that cannot be relieved in a manner that the person considers tolerable and competent to make an informed decision. And it's interesting that the architect of this legislation, ACT party leader David Seymour, said with regards to the 6-month criterion, I never supported it, I never wanted it, I didn't introduce it that way, I had to compromise because if I didn't get the votes, there'd be no law at all. So you can see how this is a kind of compromise in order to get this on the statute books with the intention that it will be expanded later. And we've seen this time and again in international jurisdictions as eligibility criteria incrementally extend over time and assisted suicide rates rise. The only red line that can hold is our current blanket ban on intentional killing. MAID accounts for more than 4% of deaths in Canada, with 7% in some areas, and this is 2022 statistics, and you can see how much it's climbing year by year. MAID tied with cerebral vascular disease as the 5th leading cause of death in Canada, whereas Oregon's annual assisted deaths have multiplied by 5 since records first began in 1998, but still remain less than 1% of all deaths there because of their much narrower eligibility criteria. And it's also interesting that in US states, euthanasia is prohibited by federal law. So that's one of the reasons why you don't see that expansion to euthanasia there. So why did Canadians seek MAID? Similarly to Oregon, Canadians seek MAID largely for existential reasons. Concern around pain control is higher for Canadians than for Oregonians, 57% versus 34%. But concern does not necessarily represent reality. And with hospice-type accessible palliative care, unmanageable pain is relatively rare. And that's because someone who deals with pain on a daily basis as part of my job. Many of the reasons cited for the indignities that make lives not worth living, the reasons we see here, are the everyday experience of disabled people. So you can see why the disabled community is concerned. So, polling. Approximately 2/3 to 3/4 of the public support assisted dying in various polls. Yet when asked what they think assisted dying means, only 6 in 10 understand it means providing people who have less than 6 months to live with lethal drugs to end their life. And this is a statistic from a poll just this week. Respondents often confuse it with the right to stop life-prolonging treatment and providing hospice-type care to people who are dying. And that's the problem with using imprecise terminology. A recent poll showed a majority support legalizing assisted dying in principle, but feel there are too many complicating factors to make it practical and safe to implement in Britain, and would fundamentally change the relationship between doctor and patient. What do doctors think about assisted dying? So in 2020, the BMA conducted one of the largest surveys of doctors on physician-assisted dying, with 19% of members responding. Those working in anaesthetics, emergency medicine, intensive care, and obs and gynae were more likely to be supportive of a change in the law. But majorities of those members who work most closely with terminally ill patients, palliative medicine, geriatricians, oncologists, and GPs were opposed to legalization. On my own specialty of anaesthetics, the Royal College of Anaesthetists conducted a poll of its members in the summer and published the results last week. With a 23% response rate, regarding a change in the law to allow physician-assisted suicide, 49% were supportive, 29% neutral, 17% opposed, and 5% undecided. Interestingly, in all the polls of physicians, there is often a substantial discrepancy between those who support assisted suicide or euthanasia in principle and those who would be prepared to prescribe or administer lethal drugs themselves. So I'm going to begin to give a more structured critique of the arguments for physician-assisted suicide, and I'm going to use a grid which many people who work in healthcare will probably be familiar with. It's from Beecham and Childress, kind of 4 pillars of medical ethics. Autonomy, which is respect for self-determination. Justice, which is treating all people equitably. Beneficence, which is the duty to do good. And non-maleficence, which is the duty to do no harm. Autonomy. There are limits to autonomy. We all agree to speed limits, which are there to prevent accidents and deaths. We all, maybe sometimes reluctantly, agreed to pandemic restrictions. And that was kind of restrictions on the liberties of the many in order to protect the vulnerable few. And even if you think about something like medicalized mutilation, if a patient asks me to chop off a healthy leg or anesthetize for it, we wouldn't just concur with that. Clearly bodily autonomy is important, but it isn't absolute. Western medicine has prohibited intentionally taking innocent human life for thousands of years, and we cross this moral line at great peril. This is a quote from Lady Butler Sloss, who was a former president of the Family Division of the High Court. It's a very powerful quote. Laws like nation states are more secure when their boundaries rest on natural frontiers. The law that we have rests on just such a frontier. It rests on the principle that we do not involve ourselves in deliberately bringing about the death of others. Once we start making exceptions based on arbitrary criteria, such as terminal illness, The frontier becomes just a line in the sand, easily crossed, hard to defend. We tinker with the law at our peril. What about the autonomy of those vulnerable patients who will be put at risk by assisted suicide? What about the doctor's conscience and our autonomy? That intentional killing is wrong is a foundational pillar in our society. Removing it necessarily impinges on the autonomy of those who might qualify for assisted suicide. It introduces external, perhaps tacit constraints on their freedom to live without guilt or fear. The elderly, the frail, those with chronic disease or disability, those with mental health problems and poor support networks are extremely vulnerable to this external pressure. We're not islands uninfluenced by the society in which we live. We live in interconnected and interdependent community. Our autonomy as individuals is shaped and conditioned by the societal norms within which we operate. This is a screenshot from the Canadian government website, which is a model practice standard for medical assistance in dying. And basically, it outlines that healthcare professionals in Canada are encouraged to make an unsolicited offer of MAID as part of a full range of treatment options for eligible patients. And often this offer is made by multiple different clinicians at various times during their interaction during that admission. They also insist that clinicians provide an effective referral to a willing colleague, even if that healthcare professional is a conscientious objector, which is a feature of the lead to bill as well. So for doctors to raise the subject of an assisted death unsolicited, and despite stating that doctors are under no obligation to provide assistance in dying, the lead to bill insists on an effective referral. I've got to say my own conscience wouldn't permit me to offer assisted suicide as a treatment option, nor make an effective referral. It's coercive and complicit. And this is the trouble. When this becomes normalized and established, professional guidelines shift and the culture shifts until this becomes an expectation. I contrast this with the current UK General Medical Council duties and standards that have been established here for a very, very long time. Patients must be able to trust medical professionals with their lives and health. To justify that trust, doctors must make the care of patients their first concern. This is how I have to behave in my profession. Decisions concerning potentially life-prolonging treatment must not be motivated by a desire to bring about the patient's death and must start from a presumption in favor of prolonging life. How are assisted suicide and euthanasia compatible with these duties? How can patients truly trust us, their doctors, when we have the power to intentionally kill them? This is a quote from a roundtable participant in quite a long document from the House of Commons Health and Social Care Committee, which I've read. It's a good document. I think it largely gives a balanced account of the issues. I disagree with some of the conclusions. In fact, there's more recent data that kind of argues against some of the conclusions in it. But here's a quote, and this is from a roundtable participant. If you then look at legislations where these things are legal, then doctors stop looking at resolving symptoms and become preoccupied with completing the process. And so the very thing that's going to change the suffering of an individual, namely medics, nurses, social workers, psychologists doing what they should be doing, which is caring for the patient, is shifted to going through a process to meet an endpoint which actually isn't going to solve the problem in the first place. Patients in Canada are being guaranteed MAID, but are not guaranteed mental health care, palliative care, disability support, and myriad other essential health services. Dignity in Dying argue that justice entails legalizing assisted suicide for those who cannot afford or who aren't able to travel to Switzerland. But justice also entails that there should be equitable access to care options for those who are terminally ill. Yet this is plainly not the case at present with respect to palliative care provision. Assisted suicide is in danger of being seen as the quicker, simpler, cheaper, politically expedient solution without addressing the wide disparity in palliative care provision. Again, this limits the autonomous choice because the options available depend on your postcode and your local access to high-quality palliative care provision. Good palliative care access will go a long way to addressing fears of a bad death, reducing costs of health and social care at the end of life by rationalising unnecessary interventions, and make for a more just provision for the terminally ill. A 2020 survey found that 1 in 5 UK residents had a personal experience of abuse as an older person, aged 65 or older, or knew a person who had been abused. Disabled people are 2 to 3 times more likely to experience domestic abuse. And here is a fascinating and revealing quote from the journalist Matthew Paris. "We simply cannot afford extreme senescence or desperate infirmity for as many individuals as our society is producing. Your time is up will never be an order, but yes, the objectives are right. May one day be the kind of unspoken hint that everybody understands, and that's a good thing." So Matthew Paris is endorsing that kind of external pressure coercion that elderly, frail, vulnerable people should be listening to. There is no doubt that ongoing care is costly and MAID saves money, as these Canadian figures show. But is this not a cause for concern when budget, staffing and resources are stretched? Pressures on NHS resources versus a fully funded assisted suicide service presents a form of structural coercion, and it's not too difficult to see a scenario whereby patients are encouraged to protect the NHS by taking a treatment option guaranteed to end their suffering. Here is a quote from the Telegraph newspaper. "It's all too easy to envisage a scenario where patients with debilitating but manageable conditions are offered a choice between long waiting lists for treatment and a far shorter waiting list for medical assistance in dying. It's easily envisaged because we have already seen it play out in Canada." And this is a quote from the Canadian Disability Inclusion Minister, Carla Qualtrough, who admitted that it is easier to access MAID than it is to get a wheelchair in some parts of the country. Is a human life more like a smartphone? Is value corresponding to the purpose it serves? And when it becomes obsolete, it should be discarded? Or is a human life more like a precious work of art? Is value immeasurable due to its inherent dignity and worth? The intrinsic value of every human being is a foundation for international equality and human rights legislation. Article 2 of the UK Human Rights Act guarantees the protection of your right to life, so a state-sanctioned assisted suicide service is incompatible with human rights legislation. It means that nobody, including the government, can try to end your life. It also means that the government should take appropriate measures to safeguard your life by making laws to protect you, and in some circumstances, by taking steps to protect you if your life is at risk. And the courts have decided that the right to life does not include a right to die. It's not too difficult to see how the progressive unraveling of the value of human life can lead to the dangers found in jurisdictions with permissive assisted dying legislation. And this is also the same justification for human rights violations throughout history. It starts with the terminally ill, then the incurably suffering. What next? The elderly frail, disabled, mental illness, those tired of life or completed life, those lacking capacity, patients with dementia, even children. And this isn't a kind of thought experiment. This is what's happened in jurisdictions like we see in Belgium and the Netherlands. Assisted suicide undermines the value of human life. It erodes trust and puts vulnerable patients at risk of implicit or explicit pressure to end their lives. It's open to abuse by clinicians, relatives, and society. It conflates problem conditions, symptoms, and diseases with problem lives, suggesting that we should end suffering by ending the sufferer. This conflation not only undermines the value of the individual, but is fraught with potential for complicated grief bereavement for families and for moral distress for physicians. Another question is, how can doctors consistently determine patients' capacity to make a decision about an intervention with such high stakes when loneliness and depression can be so subtle? In fact, the Royal College of Psychiatrists have released a report on this just before this meeting, which argues that there will be some patients who qualify for detention under the Mental Health Act because they believe their life isn't worth living, and yet they retain capacity, and so would be eligible for assisted dying. How can doctors reliably identify coercion? Death is inevitable for all of us, and sometimes comes as a mercy, but death should never be sought as a good. We alleviate suffering with holistic care, not by killing, as affirmed by the World Medical Association. And then, if we take this on, we're kind of deviating from the kind of gold standard international view on this. What about suicide prevention? Every suicide is a tragedy. Suicide is the leading cause of death in this country for men under the age of 50. It's the leading cause of death for women aged 20 to 35. Healthcare professionals are at increased risk of dying by suicide, with anaesthetists at particularly high risk. There is an epidemic of mental health problems, with NHS health, social, and mental health care in disarray. And so how does normalising suicide square with suicide prevention strategies? There is evidence from Europe and the US that unassisted suicide rates can increase when assisted suicide is legalised, as suicide becomes normalised. So I want to cast a vision for a better way, and that's palliative care. This is Dame Cicely Saunders, who was a legend in her time and was kind of the matriarch who grew palliative care into the specialty that it is, and she was British. You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. Good clinical care involves withholding or withdrawing treatments because they are not wanted by the patient, they will not work, or they are not worth it in terms of the balance of burden and benefit. Palliative care is not about ending life. It focuses on helping people to complete their lives well. It prioritizes dignity and holistic care, relieving physical symptoms and any emotional and existential suffering or distress whilst a person dies. It involves expert and appropriate symptom control, and that rarely hastens the dying process. Efforts to address suffering at the end of life should be channeled into fully resourcing palliative care with nationwide 24/7 coverage. Only approximately a third of hospice funding comes from central government. The majority is charitable. Even the increase in employers' national insurance contributions in the recent budget has threatened more hospices with closure. Their finances are precarious. Do you know in East London there's a hospice with 10 beds? They have a lot more beds, but they're only funded for 10 beds for a population of 2.5 million people. There is evidence that palliative care declines in quantity and quality of provision in jurisdictions where assisted suicide and euthanasia have been legalised compared to those where it has not. The Health and Care Act 2022 required integrated care boards in England to provide palliative care services that meet the needs of those local populations. And the recent Health and Social Care Committee report on assisted suicide recommended that the government should work to ensure universal coverage of palliative and end-of-life care services, including hospice care at home. Neither of these aspirations are yet a reality, whereas assisted suicide would be fully state-funded. So how can there be genuine choice at the end of life when you can't access the alternative? This is what we need to fix. If you'd like to read more about this, I've written a kind of academic paper in the British Journal of Anaesthesia with some of my colleagues. Feel free to take screenshots, by the way. So that's the QR code that will link you to that article. Underneath there, you can see the URL for the House of Commons Health and Social Care Committee paper, which I referenced. And there's also a paper there from some clinicians in Canada that speaks to the realities of MAID in Canada, and it is sobering. It's dystopian. This is a booklet that's available free to download by a friend of mine called Professor John Wyatt, and you can download that using that URL. And here's a paper I came across recently by a professor of ethics and law called Professor John Glen. And I found this incredibly persuasive, particularly from a legal point of view, how basically assisted suicide is unworkable and legally untenable. So, what would I urge you to do next? If you agree with me that physician-assisted suicide is unnecessary, unethical, and unsafe for patients, healthcare professionals, and society, then I think next steps would be to watch the documentary Better Off Dead by Liz Carr. It's still available on iPlayer. That will be even more persuasive than what you've heard tonight. Persuade your friends and colleagues. We need a grassroots movement that resists this from happening in the UK. I would encourage you to tweet or email your MP even tonight. John's here listening, but some of you will come from other constituencies. There is a very, very important debate tomorrow. I honestly think this will be the most important debate of our lifetime, and certainly of many MPs' careers. This vote could change the social fabric of our country, and it's important that we let our MPs know what we think. If you'd like to write or tweet your MP, here's an aid memoir, and I've used the letter C. So we've talked about compassion. Compassion on both sides of the argument, but is compassion care, or is compassion you'd be better off dead? Is there a real choice? When palliative care isn't fully funded, the NHS is in crisis, this is not the time. There's a risk of coercion, and the consequences, far-reaching, like the doctor-patient relationship. We need to look at what's happened in Canada with the slippery slope there. The conscience clauses in this bill are inadequate and unsafe. And then the answer is palliative care. If you're a healthcare professional, please sign up to our duty of care, and you'll receive emails with information about this, and you can help campaign with me.